This podcast does not provide medical advice. Please listen to the complete disclosure at the end of the recording.
Hello, cats and kittens, and welcome to Everyone Dies, the podcast. I'm Marianne Matzo.
And I'm Charlie Neverett.
So roll down your bobby socks, grab yourself a drink, get some dessert, put on your dancing shoes, and join us for the next hour as we discuss Do Not Resuscitate orders and the whole concept of that. So, Charlie, what are you seducing our listeners with today?
Well, the death by chocolate treat of the day is death by chocolate eclair cake. Ooh. Now, I'm a chocoholic, so I'm the first to admit there is no such thing as too much chocolate. You can always turn things up a chocolate notch, going from milk chocolate to dark chocolate to truffle to triple chocolate. But once you reach the peak level of cocoa obsession, death by chocolate, there is literally no turning back. Proceed at your own risk. Mini cheesecakes are the best way to get a party started, or rather, the best way to end one. Either way, death by chocolate is always the best of the best. These cupcakes are rich and creamy, and chocolate is involved from top to bottom. They're the perfect indulgence.
If you'd like to see the recipe, it's on our webpage, Everyone Dies. It's dies.org. So our next segment is our humor segment where, Will Rogers once said, everything's funny as long as it's happening to somebody else, and that includes dying and death. So Charlie's going to tell us a joke, and please send in your own death, dying related jokes for our ongoing segment on humor to email info@everyonedies.org. Remember, the one is always the number one. Or by snail mail to P.O. Box 851891 in Yukon, Oklahoma, 73085. So, Charlie, what's your joke?
Well, a man walks into a bar and asks the bartender for a drink for him and his pig. He's got this pig under his arm. The bartender gives him the drinks and asks why the pig only has 3 legs. Well, the man says, this pig pulled me and my whole family out of a house when it was on fire. I mean, he saved our lives. The bartender says, wow, that's an awesome pig, but that still doesn't answer my question. Well, the man says, there was this one time I was fishing with this pig and my boat capsized. And, I don't know how to swim, but this pig pulled me back to shore and gave me CPR. Wow, The bartender says. I mean, this pig's a hero. But, that still doesn't answer my question. Why does he only have 3 legs? Well, the man said, if you had a pig this awesome, you can't eat them all at once.
Oh.
Thank you very much. Thank you. Thank you.
Please send us some jokes.
Yes, please. So, Marianne, okay. What's next?
So, for our second half today, I'm going to chat with you a bit about Do Not Resuscitate orders, or what's known as a DNR. In our last segment, we talked about advance directives, and I've had so many times that patients will come in, admitted to the hospital and say, I have my advance directives, everything I want is in here. And what you need to understand when you're admitted to the hospital is that even if you say in your advance directives, I do not want resuscitation, that's a separate thing. That's an order that the physician has to write every single time you're admitted to the hospital. It has to be a doctor's order. So if you're on insulin or a cardiac medicine or whatever, it's not enough to say, hey, here's the meds that I'm on, and automatically expect those orders to be written. No, your healthcare practitioner has to write those orders. And we also have to write an order for resuscitation every single time. My mom had a major, huge stroke, and she coded in the hospital, and they resuscitated her. And my family was really upset. They said, she's a DNR. They weren't supposed to resuscitate her. And I said, well, I was in another state. I said, did you happen to tell them so they could write that as an order? And they said, well, no, they never asked. It's like, okay, As good consumers, you guys, you need to not wait for someone to ask. If you or somebody in your family has said, I don't want to be resuscitated, you need to be sure that when you have the list of all the medicine that they're on, that you also write down DNR so that you remember to tell the person writing the orders to put that order in. So it's an order that's written every single time, because if you did want to be resuscitated and we just assumed you were DNR, we can't go back and undo that if you were to code.
Exactly. Yeah.
So the assumption is always you're to be resuscitated unless you tell us something different. So DNR means do not resuscitate. And these are, as I said, written by a physician or a healthcare practitioner, like a nurse practitioner, physician's assistant, not to perform CPR, cardiopulmonary resuscitation. I really need not to drink while I'm doing a podcast because I can't say all the words.
Cheers.
So every time I stumble on a word, take a drink. So cardiopulmonary resuscitation,
Hang on,
CPR.
I need a refill. Sorry. I just bring the whole bottle. Yeah.
Uses mouth-to-mouth or machine breathing and chest compressions to restore the work of the heart and lungs. So you've seen it on TV a million times. I know you have. And
but how accurate? I mean, it's TV. So how accurate is it?
It's TV. Well, I'm going to talk about that. But it also looks like very neat and clean, right? It's like, push, breathe. Oh, look, don't they look pink and healthy? It is not that way in real life. Typically, when you're doing chest compressions, you're going to break some ribs. And if you've ever had a broken
the person's
rib,
the person is anxious and excited and doesn't know his or her own strength. Yeah.
No, it's not even about that because it depends on how strong your bones are. And considering where the heart is, in order to push hard enough, in order to keep the blood moving, you got to push hard. It's not about practitioners being overly excited. That's a myth. And think about who are you typically doing resuscitation on? Mostly older adults, right? And their bones are decalcified. They're brittle. Right. They're going to break. Okay? Because you've got, like this, in order to make it work, you got to really push. Okay? So this emergency rescue technique can save people's lives, but it can also result in broken ribs, which are extremely painful if you were to survive with that. You will always end up with a tube down your throat and on a ventilator, on a respirator, with this machine breathing for you. And that happens in an intensive care unit. And when I go through the scenario with people, they'll say, well, I don't want a tube down my throat. I don't want to go to the ICU. I want to die at home. Well, if that's what your goal is, then you need to think about, do you want this intervention? It's like going to a tattoo parlor and, they put this huge dragon on your arm and you say, well, I don't want that dragon on my arm. It's like, so why are you in the tattoo parlor? Get the heck out of here. It doesn't make any sense. Don't start something. Don't go into a situation where that's what's going to happen. Don't drink and go to a tattoo parlor. That's also another really important thing. There's an important
safety tip right there. Hang on, I'm going to write this down.
Thanks.
I'm sure I remember.
So CPR is really a very vigorous emergency procedure. It's not always successful. In fact, most of the time it's not. People who have a disease like widespread cancer or widespread infection or some other terminal illness, it might restore their heartbeat and it might help them breathe. But the underlying thing that was wrong, like the cancer or the infection or the terminal illness, doesn't make that go away. So all of that is still there. And now you have this other thing of having been through resuscitation.
Right.
So how do you go about deciding, do I want this or don't I want this? So some things to think about. You think about, is there going to be a medical benefit? Like I said, if you've got widespread terminal stage 4 cancer, it's not going to make that cancer go away. So what benefit are you hoping to get from having this CPR? CPR is not meant for people who are terminally ill or who have severe health problems. And it's not likely that it's going to be successful for people in those situations. The other thing to think about is quality of life. Quality of life is your ability to live your life the way that you want to live your life. Like I've had people say, when I can't wipe my bottom anymore, I don't want to have CPR or anything that's going to extend my life. Everybody's got their place where they say, if I can't do this, I don't want that. So you're looking at your quality of life. Sometimes CPR is only partially successful. The patient might survive, but they can suffer brain damage. Other organs can be permanently dependent on a machine to breathe. And this is particularly true for people who are older, who are very frail. Once they get on that ventilator, that breathing machine, people in those situations, we can't get them off. And, because the term is to wean them off the ventilator. You go on it while you need assistance to breathe, and then the idea, unless you're going to live the rest of your life on the ventilator, is to pull you off of that. And the question is, are they going to be able to wean you off? And if you're in a very compromised state to start with, it's going to be very hard to get you off. I'm not even going to say anything to that. So in the third case is if death is expected soon. So people who have a terminal illness, they might not want aggressive interventions and may prefer a more natural, peaceful kind of death. This is called allowing natural death. So you hear people talk about DNR, do not resuscitate orders, but there is also something called A&D, allowing natural death. Meaning that if you have a terminal illness and you say, I've done as much aggressive kind of treatments as I'm going to do, when I die, just let me die. And that's not giving up. That's not abandoning your family. The name of the podcast is Everyone Dies, because everyone dies. We're mortal people. At some point, we're going to die. And at some point, we need to say, when I stop breathing, just let me stop breathing. Allow me to naturally die.
So with that, and I understand that. I agree with it. So if that happens and I can't breathe, doesn't that then become, it becomes uncomfortable, wouldn't it? I can't breathe. I'm gasping for air.
Well, the point then is that's where palliative care comes in. Because do not resuscitate does not mean do not treat. We don't say, you're do not resuscitate. I'm going to put you in this far corner room and open the door every now and then and see if you're breathing or not. No. That was kind of an old-timey way of doing things, is that if you had a person who was actively dying, they would literally be put at the end of the hall and they would be considered an easy patient because you were just waiting for them to die. That's not the case with palliative care. With palliative care, we say, we're not going down the curative aggressive treatment road. We're going down this palliative road, And so, what are your symptoms? Oh, you're having difficulty breathing? Best drugs for difficulty breathing is morphine, because people think, oh, morphine, that's for pain. Yeah, it works great for pain, but it also decreases how much oxygen you need in order to feel comfortable. And so we can give you morphine, and your oxygen requirement goes down, so you're much more comfortable. So we have medicine that whatever symptom you have, we can help to manage it. So no,
and I'm sorry,
you're
was
not
something
ever left
with
gasping. What?
Well, okay, so then that's my question then. So someone's gasping for breath, they receive some morphine. They're gasping for more breath, so they receive a little more morphine. I mean, at one point, I mean, is there some, I don't know what I'm trying to ask here, not a cutoff, but is there some point where the morphine is just not going to help anymore?
No. One of there's some drugs that have what's called a ceiling effect, is that you get to a certain dosage and you could give 1 million more milligrams and it wouldn't make any difference. Morphine is not one of those drugs. You can always titrate it up, activate those opioid receptors, and it will continue to work. So you'll see people, people in hospice, people who've been going through the terminal phase for a long time, on what the average person would look at the doses and say, oh my God, that's enough to kill a horse. And they're still, awake and talking and doing things, because you develop a certain tolerance to the drug, which requires an increase of the dose. So it can be increased to infinity and beyond based on the symptom need of the patient. That's a good question.
So is there ever a point then where, but at some point, I mean, a patient will stop breathing, right?
Well, that's what, I'm not being silly, but that's what death is, right? At some point, your body will give out and you'll stop breathing.
I understand that. It gives out, it stops breathing. But at that point when it stops breathing is, and I'm taking the morphine into consideration, or, whatever medication the person's on. I mean, at that point, is the person then just gasp for breath, even though they're medicated? I mean, what is then that last few minutes?
No, they just go to sleep, and you'll look at them and you'll say, "Are they still breathing?" And you'll go and you'll take a pulse, and you'll say, "Oh, I guess not." I know this maybe sounds flip, but I'm thinking about when my mother died. It was right around Christmas time. She'd had, like I said, that really huge stroke. She was home with hospice, which was primarily that I was taking care of her. And my sister was around and my brother was around. But I spent like the 24 hours I slept there with her because I lived in another state anyway. But it was right before Christmas. My kids were there decorating the house. My sister was there. My brother was there. My sister-in-law was there. We're all doing Christmassy things. And she's sitting in her chair. And my sister glances over at my mom. And I see her looking, and I look too, and we're both looking at her, and my sister mouths to me, "Is she dead?" And I mouthed back, "I think so." And like I said, the kids are decorated, the kids are playing, we go over there, I take her pulse, it's like, yeah. It was the most undramatic thing in the universe. Now, she wasn't on morphine, and she wasn't, medicated. I don't know if she had another small stroke. I don't know what happened. But it was, one minute she was there, and the next minute we happened to notice that she had died. And I don't know how long she sat there dead. But, we were, like I said, decorating the house for Christmas and talking and eating, and she was in the midst of things. But, she could no longer talk and participate or even move because of the stroke. So it's like there's nothing but a pause sometimes between life and death. And that's okay. A good death, right?
Oh, it's a wonderful death. Yes.
It doesn't have to be dramatic. It doesn't have to be, quote unquote, a big deal. But there's just that pause, that second between that person's breathing and that person's not. And that's the goal in palliative care, is to have the symptoms so well managed that it's not traumatic for the person who's taking their last breath, and it's not traumatic for the family who's there while they're taking their last breath.
So
I mean, it was a
basically
great...
okay, yeah.
It was a great experience for my kids, in terms of being able to, because they saw my sister and I kind of looking, and they said, "Is Grandma dead?" And I said, yeah, she died. And they're like, "Oh," there's no trauma there for them.
And I think too, what made it, I mean, the girls are smart, they're very insightful, but even as kids, what I'm thinking as kids, I'm sure they also saw how you and your sister reacted. And
right.
The two of you just reacted like, well, this is what happens. You are born, you live your life, you die. Just, it's as we tell everyone, just everyone dies.
It's normal.
Yeah, it's normal. And the girls saw that, yeah.
But think how different it would have been if we had said, "Oh my God," pulled her out of her chair, laid her on the ground and started doing CPR, called 911. Imagine the difference. Imagine the trauma for everybody.
Right. Yes.
And to what end?
Yeah, exactly.
She had a major stroke. She wasn't going to recover.
Right. And that's the memory that would have stayed with the girls.
Right.
Or
right.
even maybe with you and your sister.
Interferes and causes trauma in the grief, like we've talked on a previous podcast.
Right.
We talk. Right. Also, you look at CPR on TV. Like, I'll talk to patients and they'll say, "Oh yeah, I see it on TV," and those patients always do really well. Well, there was a study that was done where they looked at medical shows on TV where CPR was done, and they found that 75% of TV patients who received CPR were alive immediately after the completion of the CPR, and 67% of patients survived in the long term. Other research has shown that shows like Grey's Anatomy have more accurate immediate survival rates, but they're still misleading. TV shows portray CPR as mostly binary. It's either full recovery or it's death. And there's very little attention given to, do they survive? Are they discharged? Do they have a long-term disability? Nobody ever says, well, okay, we did this, but now we can't get them off the ventilator. Also, TV patients tend to be younger. They experience cardiac arrests because of trauma, unlike real-world recipients who tend to be older and have long-standing heart or lung disease. That's resulting in them needing to, make for a decision to be made about resuscitation. So I mentioned allowing natural death orders, A&D orders, can be an alternative to the do not resuscitate orders. A DNR simply states that there's no attempt that's going to be made to restart breathing or restart the heart if it stops. Where allowing natural death orders or A&D orders would assure that only comfort measures are taken. That would include discontinuing or not doing resuscitation, not utilizing artificial feedings or fluids, and other measures that would prolong a natural death. Allowing natural death orders are intended for terminally ill patients only. You know that you have this disease, either really bad end-stage heart disease or stage 4 cancer. You know that you're terminally ill. So a decision can be made to, well, what happens is going to happen, and we'll keep you comfortable, and we'll treat symptoms as they come along, if they come along. You don't know what's going to happen. But by having palliative care and hospice support, you can have people who are there on your team to say, well, you're having some trouble breathing now? Well, let's treat that. Let's make you more comfortable. Research generally suggests that about 40% of patients who receive CPR after having a cardiac arrest in a hospital survive immediately after being resuscitated, but only 10 to 20% survive long enough to be discharged. So in the short term, 40% will survive it, meaning we start CPR, they're still alive. They get transferred to the ICU, they're on a ventilator. Only 10 to 20% survive long enough to be discharged. So if you're choosing to have CPR when you have, end-stage heart disease or lung disease, no, it doesn't really appreciably help your survival rate. And that's not saying that people are going to walk out and live a healthy life, that 10 to 20%. They still have the underlying condition that put them in that situation in the first place. It doesn't magically make that go away. Did you have any other questions for me about that?
No, actually that just suddenly popped into my head. So thanks for clarifying that. Maybe future.
That's why I'm here.
Yes. Maybe we can add a new feature, an occasional feature. Basically, all the stats you gave about how many actually survive, because the myth is basically what we see on TV, and it's not true. So maybe future segment, busting myths.
Mythbusters.
Oh, right. Yes, there we are. Thank you. Mythbusters.
I loved that show. My kids really loved that too.
Yes.
Well, people can write in and ask us questions, and then maybe we could bust the myths if or not. So that would be a good thing people could write in and ask us about.
Yes.
So in our third half, we found this poem called "Do Not Resuscitate" by Brenda Butka that was published in JAMA, and we're going to put it on the website, but Charlie thought he'd like to read it to you. So, Charles?
I can say your father is dying. I can say wishing will not make it so. Belief doesn't change a thing. I can say love does not conquer all. Miracles are pretty stories told in church. The movies you saw as a child are lies. Blind hope is not a recipe for success. Underdogs usually lose. Death is not the worst thing. It is just the last thing. But for you, that is not true. I can say we have to pretend that we can bring him back, wheezing back to you like an old accordion, chest pleating in and out, singing his customary songs, oxygen bumping its hurdy-gurdy way again through his ancient heart. But how can I tell you how someone will shout down the highway, kneel frantic on the bed, lean his fists against that old breastbone, sharp, frail, 1,000, 2,000, and count it out? I can say we should not do this. He will never be the same. I can say, if he were my father, I can say, do not confuse resuscitation with resurrection, although neither works particularly well. You look like you are drowning, pallid and slow in the waiting room's underwater light. So, tell me again, tell me about your father.
Welcome to our third half. We're going to introduce a new segment called Funeral Theater, where we put the fun in funeral. The scene that we're going to do today highlights our topic for this week, allowing natural death. It's a scene from the play called Wit, In this play, written by Margaret Edson, we meet Miss Baring, who's been diagnosed with stage 4 ovarian cancer and has been involved in phase 1 trials for treatment. This scene between her and her nurse shows their discussion about resuscitation status. We have Marcia with us today playing Mrs. Baring. And if you want to see the film, they did do a film with it of the play. We have that link on our webpage. So here we go. Miss Baring, is that you beeping at 4 o'clock in the morning?
I couldn't sleep.
Really? What's the trouble, sweetheart?
I can't seem to figure things out. I'm in a quandary, having these doubts.
What you're doing is very hard.
Hard things are what I like best.
No, but it's not the same. It's like it's out of control, isn't it?
Yeah, I'm scared.
Honey, of course you are.
I'm worked up. I don't feel sure of myself anymore.
And you used to feel sure, didn't you?
Yes. And I used to feel sure.
It's okay. It's all right. And it hurts. I know. It's all right. There you go. It's all right. Vivian, do you want a popsicle?
Yes, please.
Okay, I'm going to go get one. I'll be right back, okay? Here you go.
Here.
You sure? Thanks.
Thank you.
When I was a kid, we used to get these from a truck. A man would come around and he'd ring his bell and we'd all go running over. And then we'd sit on the curb and eat our popsicles. It's pretty profound, huh?
Sounds nice.
Vivian, there's something we need to talk about, that you need to think about.
My cancer's not being cured, is it?
No.
They never expected it to be, did they?
They thought the drugs would make the tumor get smaller, and it has. It's gotten a lot smaller. But the problem is it started in other places too. They've learned a lot for their research, and it was the best that they had. It was the strongest drugs. But it's just that there really isn't a good cure for what you have yet, for advanced ovarian. I'm sorry. They should have explained this to you.
I read between the lines.
What you need to think about now is your code status, what you want them to do if your heart stops beating. Well, you can be a full code, which means that if your heart stops, we'll call a code blue and the code team will come in and resuscitate you and take you to intensive care until you stabilize. Or you can be do not resuscitate, which means that if your heart stops, we'll just let it. You'll be DNR. Now, you can think about it, but I just wanted to present you with both choices before Kalikian and Jason come in and talk to you.
They don't agree about this?
We like to save lives. So anything's okay as long as life continues. It doesn't matter if you're hooked up to a million machines. Kalikian's a great researcher. He is. And the fellows like Jason, they're really smart. It's an honor for me to be working with them. But they always want to know more things.
I always want to know more things. I'm a scholar, or I was when I had shoes, when I had hair on my head.
Okay, that's fine. We'll make you full code.
No. Don't complicate the matter.
Oh, really, it's fine. It's really up to you.
Just let it stop.
Really?
Yes.
So if your heart stops beating...
Just let it stop.
You sure?
Yes.
Okay. I'll get Kaliki in to give the order, and then
Susie, you're still going to take care of me, aren't you?
of course I am. Don't you worry, sweetheart. So I think one of the takeaway messages for me in this scene is how people are so concerned that do not resuscitate means do not care, means that we're not going to do anything for you if you're a DNR, do not resuscitate. But that's really not true. And the change for Mrs. Baring are that the goals of care change more toward comfort, but we'll still care for her. What did you think about that, Marcia?
Well, I actually went through this with my husband. They came in to talk to him about signing DNR or not. And we talked about it for a while. And I said, well, for me, when he asked me what I would do, I said, I would just want to die in the arms of someone I love. And he said, all right, that's what I want, because there was nothing more they could do except, keep him comfortable, which they did. And everybody at the hospital was loving and fine and just marvelous. So he decided, right. He was so sick by then. That comforted him, knowing that I would be with him and I would be holding him and loving him when he died. And for me, I'm going to be 83. So I need to think about that. And that's probably what I want, although I won't have my Jerry there with me, but my children will be with me. And I've actually been with my mother, my father, my cousin, and my husband when they all died.
Wow.
So, holding their hands and everything. Yeah. It was very difficult, but a privilege.
Mm-hmm. Yeah, I feel that way when I'm with somebody who's taking their last breath. It's, some nurses are with people or babies when they take their first breath. Mm-hmm. And some of us are with people when they take their last breath. And each of those situations is very profound.
Yeah. I need to think more about, do I want my children with me? It's really hard, it's really hard to do that. But I'm a pretty strong person, so I might be able to handle it with a nurse or, when I get closer to that time, I'll decide how I want it. And my kids and I talk about everything anyway.
Mm-hmm. So part of the podcast from last week and this week was the whole idea that we don't ever really know when we need to have that talk. So we really need to have that talk while we can still talk. And it's never a comfortable situation. It's not one of those happy conversations. And there's actually a comic book by a New York, The New Yorker. She writes comic strips for The New Yorker. And the book is called Can We Talk About Something More Pleasant? And it's this comic book where she talks about her parents and them getting old and them getting sicker and her raising the question with them about, like advanced directives and what would you want if you were really sick? And the mother says, can't we talk about something more pleasant? And so that's the title of the book. But what happens through the book is that the parents get sicker and sicker and die. And she doesn't, have that guidance in terms of what they would do. And we talked last week in our advanced directives talk about how that makes it so much easier on family if they can look and see, oh, here's what she said she wanted, and go by that. So, the advanced directives are, you can point somebody to make decisions for you, and also say if you want artificial food and fluids, what you want, what you don't want. The DNR, though, that's different. That's a doctor's order. And, your durable power of attorney, the person you choose to make decisions, they can make that decision if you aren't able to. But like for your Jerry, he was able to say, there's nothing that they can offer that's going to cure me. And so then choosing instead to allow a natural death, that when the heart stops and breathing stops, that you just let it stop. And that's really what in this play, Vivian is doing. She's just saying, let it stop. She's not saying, I don't want to eat anymore. I mean, I don't even know in the play if she can still eat or drink, but she's saying, just if my heart stops, just let it. And, that's how people have died forever until we figured out all these machines that made it something different. Well, I really appreciate you doing this scene with me, and thank you.
Anytime you need me, absolutely. This, I think I told you that this is something that is such an important piece of work. What you're doing is I admire you, and I admire the work you're doing. So anytime.
Thank you for listening. Please stay tuned for future episodes of Everyone Dies. Our thanks to our CEO, retired Major General David, our producer Sandy, John, our technical advisor, and our friends and family who are helping make this podcast a reality. This is Charlie Navarrete.
And I'm Marianne Matzo.
And we look forward to talking with you soon.
Bye.
For now.
This podcast does not provide medical advice. All discussion on this podcast, such as treatments, dosages, outcomes, charts, patient profiles, advice, messages, and any other discussion are for informational purposes only and are not a substitute for professional medical advice or treatment. Always seek the advice of your primary care practitioner or other qualified health providers with any questions that you may have regarding your health. Never disregard professional medical advice or delay in seeking it because of something you have heard from this podcast. If you think you may have a medical emergency, call your doctor or 911 immediately. Everyone Dies does not recommend or endorse any specific tests, practitioners, products, procedures, opinions, or other information that may be mentioned in this podcast. Reliance on any information provided in this podcast by persons appearing on this podcast at the invitation of Everyone Dies or by other members is solely at your own risk.